The room is open for the attendees. You can start.
So a very good evening to all of you, and for some of my international colleagues, good morning and a good afternoon. In the same series of autoimmune subsection teaching webinars of the Indian Academy of Neurology, it's a pleasure for me to introduce today's webinar, which really talks about the core basics of autoimmune disorders, covering the facts of the autoantibodies, neuromuscular junction immunology, immunology of the encephalitis, which has become a large subset now, as well as peripheral nervous system antibodies. So this will give you a fair understanding about the core concepts, from where they come from and how do we understand them, and how do we place them when we're investigating and evaluating our patients on the bedside. So it's a privilege for me to now hand over the proceedings to my convener of the subsection, Professor Neuropathy from NIMHANS. And then we start with the first talk.
A very good evening, good afternoon, good morning, everyone. So I'll not take much time. There's been a little bit of change in the order of the presentation. So first talk is going to be from Dr. Anastasia Zakharitow. I hope I've spelled your name, ma'am, properly. So she is from the Neuroimmunology Laboratory from Mayo Clinic, who did her PhD and also worked as assistant professor in various labs in medicine, pathology, neurology at the Mayo Clinic. So Dr. Anastasia will be talking to us on various autoantibodies in CNS immunology. Over to you, Dr. Anastasia.
Thank you very much. I'm just going to quickly share my screen, and then I will just put it into a presentation mode. Can anybody see my slides okay? Good.
Yes.
Yes.
Good. Perfect. Okay. So I'm just going to put a laser and then we'll start. So thank you so much for inviting me. I will try to condense neural antibodies in central nervous system autoimmunity in the next few minutes. So these are my disclosures. I will be talking for neural antibodies that I have patents on. So this is a relevant disclosure. The rest of them is not. So I always try to start and we'll go with cases and then discuss the neural antibodies. So these are two cases that I've seen during my fellowship here. So the first one is a 74-year-old female. She was a smoker. She had a rapidly progressive encephalopathy that went into a coma in a few days, an inflammatory CSF, and then her MRI showed bilateral T2 hyperintensities. And then when we look, and this is a classic assay that you will see throughout, as I'm also going to discuss how we test for neural antibodies. This is a tissue-indirect immunofluorescence assay. So we're actually using the patient's serum and CSF, and we look for neural antibodies that bind to neural tissue. So you can see the staining that for us that look down the microscope, this is typical for AMPA receptor antibodies. So she came to Mayo from an outside hospital, and then we had a CT. We could not find anything, and then a PET scan, and we found metastatic melanoma. So this patient was treated with steroids, plasma exchange, rituximab, and chemotherapy. And even though she was comatose, she had a full recovery. Similar patient, 62-year-old woman, she's a smoker, again, rapidly progressive encephalopathy. She was not comatose, ataxia and dysautonomia. She had a normal CSF. She had a very similar MRI. When we did a PET scan, we found a metastatic small cell lung cancer. Both of them did not have primary, neither the melanoma nor the small cell. It was just a small lymph node metastasis. She was treated with steroids. We gave her chemotherapy for her cancer, and then she also got cyclophosphamide. So some would argue even more aggressive treatment than the other patient, and they died from neurological complications. So very similar presentations, very, very different types of recoveries. So I think what you will see here, this patient, when we look down the microscope, has ANA1 antibodies or anti-HU antibodies. This patient has AMPA receptor antibodies. So essentially, and I'm not going to talk too much about this because I think that Dr. Cleaver will discuss it much more, but this is a very simple way that we're actually thinking about neural antibodies now. So practically, the neural antibodies in paraneoplastic cases, the idea is that we have antigen release from the tumor cell lysis, that it's picked up by the antigen-presenting cells. It will go to the lymph node, where we will actually have the priming of the T cells and the B cells, and then what we detect in the blood, which is what or in the spinal fluid, which is what I will be talking about, is these neural antibodies, but not every neural antibody is the same. So the first patient had AMPA receptor antibodies. So AMPA receptors, they are proteins that we can find in the cell membrane. So the antibodies have the potential to be pathogenic. And then there are different ways that the pathogenic antibody can act. I'm not going to go into this, Dr. Cleaver will. And so that would be one thing. But the second part is that we also have antibodies for intracellular proteins. That was the case of ANA1 or anti-HU, where the antibodies there are biomarkers of the disease, but essentially the effectors of the autoimmunity is the cytotoxic T cells. So in this case, the cytotoxic T cells will actually find the cells that express the antigen in their MHC class 1 groove, and then they will kill the cells. So it's essentially a non-reversible process. So different effectors, even though the antibodies we detect with very similar ways. So, and then this is a slide that we keep on updating, and I feel that it gets every month almost out of its all, because we have neural antibodies that are described multiple times a year. And then it started with the striational muscle antibodies, the muscle acetylcholine receptor antibodies, which were the antibodies that are the pathogenic antibodies for myasthenia gravis. In our lab, we don't even test about striational muscle antibodies anymore. And then you can see that there is an explosion of neural antibody discovery. On the top, you have the ones that they are more intracellular. On the bottom, you have the ones that they have more pathogenic potential. So it's quite difficult to keep up with all the neural antibodies, but I think there are things that we can do to try and make this easier. So I thought, as I'm talking about neural antibodies, I will quickly guide through how do we discover the neural antibodies. So first things first, 61-year-old smoker. She came to our clinic. She had loss of balance and tingling. Over 3 to 4 months, she was diagnosed with large fiber neuropathy. And then she started having some dysarthria, diplopia, and intentional weight loss. And then when I saw her, she had tetrapendicular, ocular, and truncal cerebellar ataxia, and ataxic speech, and a length-dependent large fiber sensory loss. So this patient, when we looked at her serum and CSF, had this neural antibody, again, tissue-indirect immunofluorescence assay, that you can see that it has staining on the Purkinje cells, which is a nuclear staining. And then because we have kidney in our slides, you can actually see that it also has the podocytes in the kidney. So this is a pattern that was recognized by Dr. Lennon decades ago, and it was called antineuronal nuclear antibody type 3, but we didn't know what it binds to. And when you don't know what an antibody binds to, it's quite difficult to actually reproduce it in different labs, and it's actually easier to be able to detect it if you know what it is. So essentially, what we did for this one, well, first, we know that there is a cancer association, so we looked for the cancer, and of course, the patient had small cell lung cancer, which is a very common thing in paraneoplastic disease. She was treated with chemotherapy, steroids, and she stabilized, which when I managed to stabilize a paraneoplastic case with intracellular antibodies, I feel quite happy. So then what we wanted to do is do the antibody discovery, and practically, this is the typical more classic, I would say, antibody discovery. So you start with the patients, they either have the same syndrome like neuromyelitis optica, or they have the same staining, and then essentially you find an enriched antigen source. It can be a mouse brain, it can be a rat brain, it can be a pig brain. You purify the patient's antibodies, and then we do the antigen immunoprecipitation. We use mass spectrometry, and then essentially once we have a candidate antigen, we confirm. I will talk about those a little bit more because I'm going to talk a little bit about how we detect them. So quickly through the ANA3. So we know that patients have small cells, so we use the small cell lung cancer cell line that expressed whatever the antigen was of ANA3 that we didn't use to know. So we need the nuclear extract, and you can see that all the patients with the staining bind at the same molecular weight with a Western blot. When you elute the antibodies from here, you can find exactly the staining that you would expect for the ANA3 that we know for years in our lab. So then eventually what we did, we purified the patient's antibodies and we used this nuclear extraction to immunoprecipitate, and then DASH1 came from mass spectrometry. And this is probably 2 years of my life in one slide. So it's not as easy as it is, but that's the concepts of how we discover an antibody. And then we discovered an antibody, but it needs to be confirmed with multiple ways. So the first thing is if there is a commercial antibody for the protein that you want and it stains similarly, that's great. That gives you confidence, but it's not enough. Then you can actually use a Western blot, which is used for antibody testing less and less, but it's still a very good assay, especially in this context. And then you can use that protein, for example, and you can see that all the patients actually bind to the protein. And then you can do immune absorption experiments. So you take your patient's serum, you incubate it with the protein, and then you see that the staining goes away. That gives you even more confidence. And last, and this is the assay that you will see throughout the slides and we use for more and more of the novel newly discovered antibodies, this is the cell binding assay where we essentially use hex cells or other types of cells that we transfect with plasmids that express the protein that we want. Here you can actually see we always put with the protein a green fluorescent protein, so everything is green if you get DASH1, and then you put your patient's serum, and then a normal serum will not bind while the patient's serum with DASH1 will bind. So that's kind of the confirmation that you have to do multiple confirmations to say that yes, this is the antibody that you care about, and then you have to test negative controls that they need to be negative. So that's kind of the classic way of discovering antibodies and how do we confirm them. And then I'm not going to go through the DASH1 specific, but practically these patients, then we went back, we tested all of them, they're high risk for cancer. And then we have the new paranoplastic criteria that says if you have a new antibody, in order to call it for high risk for cancer, it needs to have a high tumor association, which it does. But to prove the pathogenic link with the cancer, you actually need to see that your cancer expresses DASH1, which in 2 of our patients, essentially the cancer expressed DASH1. So this is a high risk paranoplastic antibody. So because we talked about cerebellar ataxias and its CNS, these are the neural antibodies, extracellular and intracellular, that are seen in patients with autoimmune cerebellar ataxia. The list is growing. I'm certain that I might still miss some, but these are growing every month, every a few months. Okay, next case, a little bit of a different approach to antibody discovery. So 41-year-old guy, hearing loss, diplopia and imbalance, and then he started having tinnitus and sensory neuronal hearing loss. And if you know this antibody, you know that this is a very typical presentation that can start months before you actually have the full syndrome. And then 5 months later, he had diplopia, worsening balance. And then when we examined him, he had ataxia, gait ataxia, hearing loss. And then he also had some multidirectional nystagmus, square waves. So the MRI was normal. He had an inflammatory CSF. And again, if you look down the microscope, he has these tiny dots that for years in our lab, we were trying to discover this antibody, but it's not easy to find an antigen source, as I showed you the first time, where you actually can find these tiny, tiny dots, have enough antigen to prove the antibody. These patients, we know that they have testicular seminoma, and it was the case in this patient. Again, it was found resected and the patient was stable, and this patient has Kelt's like 11 antibodies. These antibodies were eventually discovered with a collaboration between Mayo and UCSF with this phage immunoprecipitation sequencing. So in the past, MAT2 antibodies was the same thing. They were actually discovered with a little bit of a similar but different technology called CREX. Now what we do is more this phage immunoprecipitation sequencing, where we essentially use these phage vectors that we will express the full human proteome in overlapping peptides. And instead of using like an antigen source like a mouse brain, we will use that in order to try to immunoprecipitate and find the antigen that we care about. Again, years of work in one slide, but just to give you an idea of all the different ways that we approach neural antibodies. Now, limitations with that is, and I'm certain Dr. Vincent Cleaver will talk about how some of the antibodies, they need to find conformational epitopes to bind, so they need the protein in their native form. So we will not be able to use this method to find antibodies that bind this way. So just a hint here as well that there are other technologies now, these like full-length protein arrays. They express 80% of the whole human proteome. The proteins have a little bit more of a conformational antigen, but again, it's not perfect. It's not what you see in the patient's bodies, essentially. Okay, Kelch-like 11, same principle, like the patients have testicular tumors, it's a high-risk antibody, it's expressed by the seminomas, so that's another antibody that makes it the high-risk paraneoplastic. So if you look at the encephalitis, limbic brainstem, like these are the antibodies that we have, and the list is growing as well. Okay, third case where I will try and go through the different forms for the neural antibodies. So 76-year-old woman, diagnosed with metastatic renal cell carcinoma in 2015, treated with metastatic and primary resection. She was put on pembrolizumab. 3 months later, she started having this hyperkinetic movement disorder, essentially, you see here, with some of choreic movements, some dystonic movements, dyskinetic movements, a little bit of a maze phenotype. And then her MRI showed bilateral basal ganglia hyperintensities, tissue-indirect immunofluorescence, so the staining of the patient's antibodies to the basal ganglia. This patient was treated with steroids, and you will see she got better. This was in a post-checkpoint inhibitor context, so this is pre-existing autoimmunity probably in her that was kind of unleashed with the use of checkpoint inhibitors. This is her after steroids, so she had PD-10A antibodies. So another phenotype that has many different antibodies that can go with it. And in the realm of hyperkinetic movement disorders, like I think that we can also people here can recognize this very like everywhere type of movement without stopping of the saccade gene between this is opsoclonus. So we need to be thinking about antibodies in hyperkinetic movement disorders as well. In isolated myoclonus, it's rare to find antibodies, but opsoclonus, myoclonus, we need to be thinking of ANA2 or anti-RE antibodies. In neuroblastoma, we see the opsoclonus, myoclonus in kids. We rarely find antibodies. If we do, is ANA1. Again, if you think of the hyperkinetic, the myoclonus, the PERM phenotype, and the glycine receptor antibodies that were described by Professor Vincent. And then there are different antibodies that have encephalitis and myoclonus, and I have some of them here. So hyperkinetic movement disorders, these are some of the antibodies that we would see. I will go very quickly through this. This is a patient essentially with a progressive myelopathy, smoking, and 40 pounds weight loss. And you can see that this is a very longitudinally extensive. This is a tractopathy. The patient had blurry vision as well. So these are the antibodies that you would expect. The patient has small cell and then have CRIM5 antibodies. I just put this here because I find this one of the best pictures to actually look at the myelopathies. And this is the continuum with the different imaging. So these are the neural antibodies that we would see in patients with autoimmune or paraneoplastic myelopathies. So focus back. These are this is too quickly to talk about all the CNS neural antibodies, but these are the phenotypes that we think of, and these are some of the antibodies. So let's go back on how do we test the antibodies. I talked about this indirect immunohistochemistry or immunofluorescence assay, and this essentially we recognize patterns. Once you recognize the pattern, you need an antigen-specific assay to confirm your pattern. And this can be a Western blot or a line blot. We talked about the cell-binding assays. There are also the ELISAs that have a tendency to false positivity in low titers. And then there is the radioimmunoprecipitation assays, which are older generation assays that are still very useful for some of the neural antibodies. But again, in low titers, we need to be careful about the interpretation. So when we think about neural antibodies, we need to know how we test for these neural antibodies and what the results that we are getting are. This is one of my favorite papers, and they came from the Lyon group, and they took patients and they tested them only with these line blots that they're commercially available and easy to do, which makes it that a lot of labs would use that. The problem with that is that they have a lot of false positives. So if you look, for example, for the anti-YOR PCA1, only 6% of the patients that actually were positive did have PCA1 autoimmunity when tested with 2 different methods. And the methods are actually the tissue-indirect immunofluorescence assay with a confirmation. So depending on the assay, you might actually have a lot of false positive results. Second thing, and this is all work from Oxford, so We used to think about the potassium channel antibodies, but then it was discovered again that the LGA1 and the Caspr2 are really the antibodies that we care about in the potassium channel antibody positive patients. So these antibodies are now a little bit obsolete, and we're testing for LGA1 and Caspr2. So again, we need to know if your neural antibody, what is it still useful to test for, and then what does it mean? Third consideration when you think about neural antibodies is sensitivity and specificity. So the first discovery of ACO4 antibodies, it happened because we saw that there is tissue-direct immunofluorescence staining on the patients, that it was very specific. But we know now that this is less than 50% sensitive. ELISA is not that sensitive, is not that specific either. So now we have cell binding assays and ideally flow live cell binding assays for ACO4. Then, so this is a slide, it's a busy slide, but every antibody has a little bit of a different optimized method. Some of them have similar, but there are different optimized methods for any specific neural antibody. So we need to know, you don't necessarily need to know that, but we need to know the limitations of the assays that we're using. Very quickly, this is another patient that came to me for stiff person syndrome. She had anxiety, she had low back pain, her exam was normal, she had some functional signs. She didn't describe the typical spasms of stiff person syndrome, but she was still diagnosed with it. She had normal imaging, normal CSF. We actually did an EMG, a movement study, everything was normal, but she was still diagnosed because she had a low titer GAD65 antibody. Well, GAD65 antibodies in neurological autoimmunity are always high titer. So if you get a low titer GAD65 antibody, it goes in patients with systemic autoimmunity. And this patient had diabetes type 1. That's why she had a low titer GAD65 antibody. So how you test and knowing the results, it makes sense. So for example, we test for GAD65 with a radioimmunoprecipitation assay. So we know that neurological autoimmunity is above 20 nanomoles per liter. The lower titers are systemic autoimmunity, or you can even find it in normal people. If you test with an ELISA, the consensus is that the high titer that you would expect in neurological autoimmunity is 10,000 and above, while sometimes you get a result that says above 250 that doesn't even make, you don't know what it means. So antibody levels do matter depending on the antibody. Similar with Caspr2, we see that we have some false positives in low titers with a commercial assay. I'm certain that in like other assays, that they are live assays, they are better, but with the commercial assays, you see that there is not a specific in low titer. So one last thing, titer again, MOG antibodies. We use flow assays, we use a secondary that it's very specific, but still in low titer, you can actually have false positive results. So we need to actually be certain to recognize. So the clinical picture is what guides and antibody helps, but if the antibody does not make sense, look at the caveats that I talked to you about. And then we have this discussion, should they be testing serum, should they be testing CSF, what is the best way to test an antibody? And if you're thinking about CNS autoimmunity, autoimmune encephalitis, the short answer is both. Of course, like in myasthenia, you will test the serum, but the short answer for these types of diseases is both. You can have false negatives. So sometimes the LGA1 antibodies, we see them more easily in the serum. The ACO4, they're more sensitive in the serum. They're very specific in the CSF, but it's more sensitive in the serum. You can have false positives, NMDA receptor antibodies in the serum. I don't even care about them. I don't even test for them if I can. It's really the CSF that is actually what you need to be seeing. So they are only specific if they are in the CSF. And as I said, some phenotypes only need one or the other, but this is very rare. And then people used to send, I will test for NMDA, and if it's not that, I will test for LGA1, and if it's not that, I will test for ANA1. This is almost impossible, except for very specific presentations. So this patient, I think, had ANA1, this patient had LGA1, the MRIs look very similar. So practically, I think the good idea is to test for antibody panels. So an autoimmune encephalitis panel with multiple antibodies, rather than starting with the one, going to the next one, going to the third one, going to the fourth one. You're wasting time and serum and CSF. So the last thing I think that I will be talking about is when antibody results do not make sense, and we see this a lot. I practice in a tertiary center, so I see the case often that do not make sense. So the first thing is like, was the right specimen tested? So if you see a typical NMO, I've seen this actually, I took out the case because we didn't have time. It was typical neuromyelitis optica, there was no doubt about it. It was only ACO4 was only tested in the CSF, was negative. We tested in the serum and the patient had ACO4 antibodies. Was the best assay used? I talked about the false positive risk with some of these assays. was the antibody tested after immunotherapy. So some of the antibodies will, if you plasma exchange a patient, you might not find the antibody in the serum that you take the next day. So just consider the treatments when you're actually having negative results, also false positive results. IVIG, like as I said, low titer GAD, you will see normal population. IVIG will have you have low titer GAD. That does not make it neurologically significant. Is the antibody specific? We talked about BGKC. Striational antibodies was another one that we used to test a lot for myasthenia, but now we know that like practically striational antibodies are not that useful anymore. They don't really self-diagnose myasthenia. They're not that good for cancer in our experience either. And then are the antibody titers compatible with neurological autoimmunity? I talked about GAD65. There are different antibodies in this word. So just to finalize, and I hope I was not too over. So novel neural antibodies are discovered on a yearly basis. Clinical and analytical validation for every new discovery is critical because we have so many, we need to be confident that if we test for them, it's really something that we need to be doing. They help diagnosis cancer search and suggest the underlying disease pathophysiology, but we need to interpret them in the clinical context. Some neural antibodies are no longer useful, and we discussed about that. We now don't test for one specific antibody, but this has evolved and we have like phenotype specific antibody panels because there are just too many antibodies to be testing one by one. And if an antibody result does not make sense, consider the potential testing confounders. And again, a negative result, and I took a case that I had out, but like a negative result does not mean that this is not an autoimmune disease. It just tells you that, you know, maybe it's seronegative, maybe there is an antibody that's yet to be discovered. So if you do have a typical presentation of a patient, I always look for cancer sets, and if I'm convinced, regardless of if there is or there is not an antibody, I will do an immunotherapy trial. So that's kind of what I had for neural antibodies in the central nervous system, and I'm happy to take any questions if there are.
Thank you, Dr. Anastasia. That was very excellent presentation. You brought on very nicely about all the hard work which is being done whenever an antibody is being discovered, as well as how to go about and the phenotypic correlation, especially with the GAD and the samples which has to be tested. I think very, very relevant, especially when we're trying, at least in our setting where we'll not be able to get the whole antibody panel. Dr. Rohit, you would want to add anything?
I think we can take that about 3 questions in the.
Dr. Anastasia, there are a few questions. One of them, Dr. Donna asked, she has a lady with C1D and 5 years history of slowly progressive myopathy, with serum BGCC being positive, moderately high titer, MRI being normal. So what is your experience with this?
I don't think we don't test for voltage-gated calcium channel antibodies in myelopathies. In the right context, they are great antibodies if you have a Lambertiton patient, if you have an ataxia patient, but like we don't test for this in myelopathies. So a diabetes type 1 patient is 5 years of age. Sorry, I don't know how old is the patient. So it's slowly progressive myelopathy. That would be unusual. So diabetes type 1, it tells me that probably there is some systemic autoimmunity that can actually do low titers. If the patient is a smoker and they are older and they have high risk, you might want to check for cancer if you have the antibodies, but I would not make anything on these antibodies in this context. What I might say though, if they have diabetes type 1, if we're certain, if this is a non-lesional myelopathy, just make certain that this is not a high titer GAD and it's a stiff person syndrome rather than a myelopathy. That's kind of the main thing if I see this history. So yeah, the potassium channel antibodies in the myelopathy context, I don't think they're very useful. Just make certain that the cancer, high risk cancer is not there.
You spoke about serum NMDA being sometimes false positive. So is there one of the questions from Dr. Karthik is about what are the reasons for false positive NMDA and how to go about it?
So NMDA receptor antibodies in the serum, they're neither specific nor sensitive. So they're just not helpful. So you can see false positive, like you can see NMDA receptor antibodies in the serum in normal people. I suspect some of them will have hypergammaglobulinemia of a reason, and you might see this, but they're just not useful. Initially, we were thinking, okay, should we be looking for cancer in them? You don't find them. They're just a false positive antibody. We know that the serum is not useful. And a lot of the papers that were done in psychiatric diseases, presenting like a pure psychiatric with no other clinical presentations, a lot of the initial studies were done with serum samples for an MDA. So unfortunately, like they're just not specific. Also, if you do have an MDA encephalitis, they're also not sensitive. So you might not even find them in the serum and you need to test the CSF. So different reasons might be, but practically there is a lot of experience now that they're not very specific. Might be better if you use so in the criteria, if you're using a live cell binding assay and an MDA with serum, your specificity increases, but I still think that the CSF is the best way to actually test for these antibodies.
Usually when we start treatment and we find some antibodies positive, do you recommend that we serially test the antibody later? And what is the time duration for any antibody to come down in its titers?
So antibodies that will bring you false positive, like treatments that might lead to false positive result is often IVIG. So for me, IVIG, you just need to know what to expect, I would say. You're not going to find a false positive ANA1 or anti-Hu antibody on a tissue indirect immunofluorescence with IVIG. Like these antibodies are not part of the IVIG compound. You will not find this, but you will find a low positive GAD. You might find a low positive voltage-gated calcium channel if you're testing with a radioimmunoprecipitation assay because of the hypergammaglobulinemia and the presence of the GAD65 in the general population. So if you know what to expect with the IVIG, you can test directly, but my opinion would be if you're really looking, IVIG, I would say 3 months after I would wait to kind of test. And if the question is the opposite about false negative results, let's say you did plasma exchange and now you don't have the antibody, that's difficult because some of the antibodies, ACO.4, even if you plasma exchange, we still see them like with treatment, with rituximab, the patients almost never go seronegative, but that's a more difficult question. So I would say in patients with rituximab, for example, at least 6 months if you don't see it. In patients with plasma exchange, probably a month, 2, like it's closer, so you will have the repopulation afterwards. So it depends on the treatment, but at 3 months, it's a good rule for the false positives, I would say.
Thank you, Dr. Anastasia. We have still many questions, but I think we'll take at the end of the session. We'll go to the next session. Thanks a lot again. It was an excellent talk, Dr. Anastasia. Over to you, Dr. Rohit. Professor
Okay.
Vincent's talk we can handle.
Yes. So thank you, Dr. Anastasia. And it's a pleasure for me to introduce Professor Angela Vincent. Professor Angela Vincent is an emeritus professor of neuroimmunology and honorary researcher, Department of Clinical Neurology and Weatherall Institute of Molecular Medicine, University of Oxford. It's been a pleasure knowing Professor Vincent for almost 2 decades now. And we had a pleasure of her have been in Delhi in 2005 and thereafter in few of the other meetings. Professor Vincent needs no introduction, actually. She's such a well-known figure in the field of neuroimmunology from the days when neuroimmunology was a nascent subject. And with her research and with her contributions to neuroimmunology in many facets, she's published over 500 papers and many review articles. And we've learned a lot from her publications for both clinical and diagnostic management of many disorders. Neuromuscular junction disorders is something which is very close to Professor Angela Vincent for her original work to understand how neuroimmunology actually hits the targets. So with this brief introduction, I would hand over to Professor Angela Vincent not to lose time so that she can breeze us through the immunology of neuromuscular junction disorders. Over to you, Dr. Angela.
Can you hear me?
Yes.
Good. I'm sorry about the mess up. I was getting confused with my own versions. Anyway, I think this is the correct one. And thank you very much for going first, Anastasia. And what a very good and comprehensive talk it was too. So in a way, it's a bit of a relief to go back to the neuromuscular junction, which is much less complicated than the CNS. So I'm just going to show you my conflicts. The only important one is I'm not a neurologist, and all the opinions I give out here will be my own. So the neuromuscular junction, as I'm sure you all know, is a very important site of antibodies and indeed neurotoxins and genetic diseases as well. It's a fantastic synapse. So, of course, the nerve ending releases acetylcholine. That binds to acetylcholine receptors. The ion channel opens. There's an end plate potential which is generated. And if that end plate potential reaches a threshold, it opens these sodium channels at the bottom of the folds, and those open and then produce a propagating voltage-gating sodium channel action potential along the fiber, and that leads to contraction. And the miracle is that it can all happen in, well, fractions of a second. So it's a fantastic synapse to study. We started measuring antibodies to the acetylcholine receptor, which, as you know, are the main target for antibodies in this condition. We used the assay based on John Lindstrom's in 1976. And these are some data from Professor John Newsom Davis's clinics. And you can see just on the left how we measure the antibodies. The receptor is extracted from muscle or from cell lines now. We add radioactive bungarotoxin. Bungarotoxin binds to the acetylcholine receptor on both alpha subunits, and we radioimmunoprecipitate using the patient's antibodies. And you can see the results. The controls are all less than, which is about 2 on this scale, or 3, I can't remember what we used here. And there are some patients who are negative, and we'll come back to those in a moment, particularly ocular, but mostly we study these patients with generalized disease, but no acetylcholine receptor antibody. But you can see also rather surprisingly that there's an enormous range of antibody titers on this log plot. And a lot of people are quite skeptical about the role of these antibodies. They said they're just going to be secondary, they're not important. So it was very important to show that they probably were important. And to measure the antibodies, we had to titrate each serum accurately. And that's something I just wanted to mention, which is quite time consuming. And also it's very, very seldom done by any routine labs. So if you try to use routine lab titers that they give out very readily to determine whether a patient is responding to the treatment or not, you probably won't get very sensible results. It has to be done very carefully. And I started doing it very carefully. It was a long time ago, before I got silly and lost things and got confused. And the first cases that we really looked at were John Newsom Davis's cases of plasma exchange. And this was probably the first patient ever plasma exchange for myasthenia gravis. She got better. She'd had thymoma-related myasthenia. She'd had the thymoma removed. Myasthenia didn't get better. She was not on any other treatments at that stage because it was before immunotherapies. And so when we plasma exchanged her, or when John plasma exchanged her, her antibody titers came down. And a few days later, her clinical strength would go up. Subsequently, because there was no immunotherapies, the antibodies came back up almost to exactly the same level, which is interesting, and the patient's strength goes away. So there's a very nice correlation between antibody levels and strength in the individual patient, but not between patients, just in the individual patient if you measure the antibodies carefully. So what do the antibodies do? Well, first of all, very importantly, they're IgG1, and you'll probably hear something about different subclasses of the CNS antibodies subsequently from Jonathan. Oh, I'm sorry, that's annoying. These antibodies are divalent, of course, and they can cross-link the acetylcholine receptors. And that's because the acetylcholine receptor has 2 alpha subunits. So antibodies to the alpha subunits can cross-link like this. And when they do that, they internalize the receptor, and that leads to its destruction. Also, of course, antibodies that cross-link and form sort of clusters of IgG can activate complement. And here you see the C3b of complement, as it were, attached to the antibodies. And then eventually, with the classical pathway, the membrane attack complex, which leads to destruction. So that is a very damaging mechanism of action. Some of the antibodies, but really rather few, can bind to the acetylcholine binding site, which is not the same as the antibody binding site here. It's a different one. It's here, and cause direct block of function. But those antibodies are generally rare, although I will mention them before the end. So the antibodies in myasthenia, they get easily to the neuromuscular junction. They cause internalization, and they cause damage to the neuromuscular junction surface, although it's very localized to the neuromuscular junction. The rest of the fiber is fine. But there's some things that happen. I wanted to draw your attention to this. First of all, as pointed out by Ruff and Lennon, the loss of these folds with the sodium channels means that you have to increase the threshold to generate the muscle action potential. So actually, the loss of the folds means that the disease is worse than it would be just from the loss of acetylcholine receptors. And you can see that there aren't enough acetylcholine receptors on the surface. But at the same time, the muscle knows that something's going wrong. It tries to make more acetylcholine receptors, and that was shown a long time ago now. But what's also rather intriguing is that the nerve terminal also seems to know what's going on and starts to release more acetylcholine, as demonstrated here. So that retrograde signaling is very intriguing, and we don't really understand it. But it shows how much more we still have to learn about the neuromuscular junction. So what determines whether there is transmission failure in an individual muscle? Well, just for fun, think about it. Morphological damage, compensatory pre- and postsynaptic changes, which may be different in different muscles or between different patients. What about the blood flow during temperature, exercise? That would alter the diffusion of antibodies, increase the diffusion of antibodies in complement through this tiny space of the neuromuscular junction. So no wonder the final result is unpredictable. Cool down a muscle, it may get stronger. Warm it up, it may get less strong. Another important aspect to know about myasthenia and its immunology is that, of course, there's an early onset myasthenia, which in the old-fashioned terminology was HLA-DR3. Oops, sorry. And a late onset myasthenia, which in old terminology was DR2. I'm so sorry, I don't know. My fingers must be sticky. And in between the ages, you get some OMA patients, but they're only about 10%, and I'm not really going to mention them very much. But what you can see here is that early onset myasthenia is mostly females, as you all know. But what's intriguing and increasingly identified is that there are late onset myasthenia gravis patients. They're frequently males. And in fact, we have all diagnosed patients in their 80s, 90s, and even in their hundreds with first episode or first apparent episode of myasthenia. So it is a disease of late onset, and you should always be looking out for it in patients who have late onset weakness. The thymus, of course, is often enlarged and abnormal in myasthenia, but only really in those younger patients, the early onset myasthenia. Typically, it has lymph node-like infiltrations or follicles, rather like lymph nodes. And a long time ago, we showed that if you take the lymphocytes, which are partly B cells from the thymus, and culture them in vitro, you can show that they're actually making the acetylcholine receptor antibodies spontaneously. You don't have to stimulate them, they are already doing that. So there must be plasma cells in there, which of course we have subsequently found. So the thymus removal obviously should make the patients better, and it's been done empirically for a long time. And then, of course, recently, well, 8 years ago, Gil Wolf in the States published the very impressive, I think, thymectomy trial, which was the result of a NIH grant, which actually was initiated by John Newsom Davis, who very sadly died in 2007. And it just compared simply prednisolone with prednisolone and thymectomy. And I think you can see on the two graphs that the lower plot of each is at the top, the quantitative myasthenia gravis score went down further in those patients who had thymectomy. And what was more important in some respects is that they actually needed less prednisone to remain symptom-free. So that was really a very satisfactory result of the trial. But about 15% of MG patients do not have AChR antibody, and yet most seronegative patients improve clearly with plasma exchange. So there must be another antibody. And of course, that antibody is to MuSK, and this is really our sort of index case for MuSK. Little girl who was 2 years old and looking great. And then by 3 years, you can see a very myasthenic face, and also rather swollen because she'd already started steroid treatment for possible muscular dystrophy. And it was John Newsom-Davis who decided or diagnosed her on the basis of her clinical features as having myasthenia, and he did plasma exchange and she got better. But it can be difficult to treat this condition, and you can see here now that there's often atrophy of the tongue in these long-term untreated patients, although that's much less common now with new treatments. She finally had rituximab and in fact did seem to get better, although it was not objective, it was subjective. You see very poor function there. So, of course, at the time when we first studied that patient, we didn't know about MuSK. It was only reported in 1994, but we looked for MuSK antibodies with a colleague in Germany, Werner Koch, who unfortunately also died in 2005. And we found MuSK antibodies in a high proportion of those patients who didn't have AChR antibodies. So MuSK myasthenia is mostly younger females, but few children. In fact, not usually children. Often marked by involvement with atrophy, but we don't really explain why. That is more severe than in typical myasthenia. Often responds poorly to choline esterase inhibitors, and some people won't use them in MuSK antibodies. Myasthenia. Thymus is usually normal for age, and thymectomy is not usually undertaken because most people think it has no effect. It can be difficult to treat effectively, but rituximab seems to be very, very effective and is used now pretty frequently. And MuSK antibodies are IgG4, and you can see on the left an IgG4 antibody. And what has been shown, and which is known from other studies, is that IgG4 molecules tend to fall apart, and they then marry up with any other IgG4 half molecule that is in the circulation. So you get these hybrid molecules where only one of the arms is actually binding to your antigen of interest. And because of that, and because IgG4 antibodies don't activate complement well anyway, these patients don't have a complement-mediated disease, at least not in most cases. What we know they do, though, is to inhibit LRP4 from binding. So this is just a very crude scheme of the agrin, LRP4, which is here, MuSK complex. And without the antibodies, this would form a complex which would activate clustering of the acetylcholine receptors. When the antibodies are present, they inhibit that clustering, and the acetylcholine receptors tend to disperse and not remain clustered. And as you'll see in a moment, clustering is important for the acetylcholine receptor. So that's all I can say because of time. But what I did want to point out is that MuSK antibodies are actually different in frequency around the world. And it seems to relate to latitude, although obviously there are some parts of the world where the latitude is lower, for instance, in the southeastern Pacific, which is where we've got some of our data from, the MuSK antibodies seem to be very rare indeed. Those are the green blobs, and those are all below 30 degrees of latitude. The highest values seem to be around 40 degrees latitude, and that's the Mediterranean equivalent areas of the USA. So India is not represented on this figure. And I'm very sorry to tell you that, because I was very interested to find any data that you have that would help me add some more points to this rather intriguing graph. And we don't, of course, understand why this is such a geographically related type of myasthenia. It's not just the bulbar muscles. It can be, in this case, it was a rare case, but a child with muscle weakness, which was not put down to myasthenia initially. 5 years later, somebody thought of testing the antibodies for MuSK, and in fact, she then had physiotherapy and immunotherapies, and her scoliosis improved quite considerably, as you can see on the right. But there's another aspect of the structure of the neuromuscular junction which is important, and that's the clustering of the receptors. So that made us think about something, and what we thought about was that perhaps there are antibodies in the serum of some of the remaining seronegative patients that could bind weakly to the acetylcholine receptor, but not strongly enough for the precipitation test. And what we could do to try and remedy this problem was to set up a cell-based assay. And this was probably the first cell-based assay that was set up actually for any antigen regularly. So what we did was express the acetylcholine receptor in cells, and we clustered the acetylcholine receptor with rhabsin, which is a clustering protein at the neuromuscular junction. And then we asked, does the patient's yellow antibodies bind to the acetylcholine receptor, assuming that they're binding in such a way that they can now grab with both arms at once, which would be much stronger binding than hanging on from one with one arm in solution. And then we looked with a red fluorescent secondary anti-human IgG antibody. And you can see here on the left, there are lots of red clusters on a big cell, a hex cell. And on the right, you can see the green cell with red. And in fact, the yellow clusters are now where the acetylcholine receptor, the MuSK antibodies have bound to the clusters of MuSK. I'm sorry, what am I talking about? The clusters of acetylcholine receptor. I apologize, it shows how old I'm getting. So clustered AChR antibodies are found in perhaps up to 60% of selected patients who are negative for both MuSK and acetylcholine receptor antibodies. And the reason I came back to this was because I think the cell-based assays are very useful for many things, as you've already heard, of course, from anesthesia for the CNS antigens, but also in myasthenia. It's not just improving the sensitivity of the assay. These clustered AChR antibodies are helpful in some patients, and they're quite helpful in children who often have seronegative myasthenia and can have genetic forms of myasthenia, and you must distinguish the autoimmune from the genetic. One of the things you can do with the cell-based assays is to look for complement deposition, and because of time, I'm going to move rather fast now, and that can be quantified, as you can see on the right, and in fact, in that case, it's the score of complement in several different patients using the hex cell assay actually correlated quite nicely with the jitter that had been found. And that may be a coincidence, but it looked quite interesting. Complement, of course, is now very much the very popular topic in myasthenia because there is, as you will know, eculizumab and other anti-complement drugs which have been used in myasthenia and in neuromyelitis optica. And in fact, it's very important now to start using those complement assays to determine which patients are likely to respond to these very expensive anti-complement drugs. Because certainly they're very effective when they work, but there are a proportion of patients who don't seem to respond to the anti-complement monoclonals. And this is a paper from Kevin O'Connor's, where they were using similar sort of approach to what I've just shown you at the complement activation in each patient's serum in order to see which ones were good at activating complement. And there was certainly a variability, and in some patients, there was very little complement activating ability in their antibodies. So something for the future. Now, just lastly, I must mention maternal antibodies because although this is very, very rare, I think it's something you should be aware of. As you know, most patients with myasthenia have normal babies. Some babies have neonatal transient myasthenia. And very rarely, this condition called arthrogryposis multiplex congenita occurs. And this is caused by lack of fetal movement in utero of any kind. And there's a very rare form that is caused by maternal antibodies. And here is the sort of index patient, as it were. This mother had 4 babies. Each one of them had arthrogryposis in utero, and only one survived because not only do they have fixed joints, which you can see in the picture there, but also their breathing hasn't been established, their breathing movements haven't been established, swallowing is probably impaired too, and they don't survive after birth. She, in fact, had myasthenia gravis, which had not been recognized before. She had high AChR antibodies treated with plasma exchange, steroid IVIG, and then went on to have a son who was very slightly affected and developed perfectly normally. And in fact, then 2 further sons who aren't illustrated here. So she had 3 children after the treatment. And she remained on, I think she's on azathioprine actually even now. So this is a treatable form of maternal mediated fetal condition. And we worked out many years ago that the antibodies were binding to the fetal form of the acetylcholine receptor, which has a gamma subunit at the top there, rather than an epsilon subunit in the normal adult form. And the antibodies were actually inhibiting function. So they were crossing the placenta and pharmacologically almost blocking nerve muscle transmission. They were paralyzing the baby in utero, and that was responsible for the arthrogryposis. But recently, and this only came out less than a year ago, it's become clear that many of the mothers who have those children may have further children without without any intrauterine severe problems, and the babies survive. But quite a lot of them have changes postnatally, which are much more myopathic than neuromuscular junction. So they're not myasthenia. The antibodies have long gone, but many of them have a rather typical faces, which you can see, for instance, here. They tend to have long faces, these little boys, a V-shaped, inverted V-shaped mouth, which is quite a typical finding. Sorry. And it's a really intriguing situation because some of these mothers don't even have clinical myasthenia. So you have to look for these antibodies in mothers who have at least 1, if not 2 consecutive children who have developed apparently sort of normally, but have this myopathy. And I do, if anybody's interested in the more pediatric side of this, might well like to look at this paper for details. What's also intriguing is that, of course, the anti-FcRn treatment, which is now being made by several companies and used to reduce titers of AChR antibodies, they also reduce placental transfer of maternal antibodies. And that's what that FcRn, in fact, was first discovered as, the Fc receptor that transferred IgG from the mother to the babies. So the antibodies to the FcRns, which are now being used in myasthenia gravis, they could also be used to help reduce the transfer of antibodies to the babies. Right, lastly, I just thought I'd better show you this. There have been a lot of antibodies mentioned in myasthenia. They are sometimes specific for myasthenia gravis, but not necessarily. You have to be very careful about their roles. 2 of them, the ones circled in blue, those are very common in thymoma-related myasthenia, but I don't think they're necessary for the diagnosis. And in fact, we usually just use the thymoma scan and the AChR antibody, which is almost invariably positive in thymoma cases. So the only antibodies we regularly do and pay attention to are the MuSK and AChR antibodies. And the other ones that have been mentioned by many people in the past, we really don't find particularly useful, except for the fetal receptor antibodies in some of those mothers, where those are essentially the only antibody that they have. And to measure these antibodies now, most of the labs are using the cell-based assays, which are now, I think, available from the company that makes them, which unfortunately you can see there, but I'm sure everybody knows about this company now. And in fact, on a single little chip, you can see that there are cells expressing MuSK, LRP4, if you want to measure antibodies to that, ADAUT, and fetal acetylcholine receptors. So all of those 3 or 4 antigens can be measured in a single well on this slide. And that's what a lot of the companies will be doing in the future, if not already. So in summary, AChR antibodies are IgG1. Complement activation is important, but not in all patients. For others, complement activation is less important. These may not respond to anti-complement treatment, so we need to be able to measure complement activation. MuSK antibodies are IgG4 mainly, but not entirely, and act by inhibiting the Agwin LRP4 MuSK pathway. And the only way you can treat them at the moment is by removing the MuSK antibodies, although there are some potential other ways of treating them. Myasthenia still provides a paradigm for antibody-mediated disorders, and in fact, pharma often go to myasthenia first to test their novel IgG, B-cell, and complement depleting therapeutics. So I think it's still worth studying myasthenia gravis, and I hope some of you might do that. And here are some of my most recent fellows involved in the studies, and Leslie Jacobson, who's done a lot of the assays over many, many years. Thank you. I'll stop sharing.
Thank you, Professor Angela, for such a detailed and lucid presentation from inception to our understanding. And I think some of the historical aspects really make us understand how we have grown to understand neuroimmunology. So we have a question from one of the attendees, which talks about differentiating congenital myasthenia from a suspected autoimmune myasthenia in a younger patient, but who's antibody negative. So sometimes in clinics, we do have this concern whether there are features of congenital versus acquired seronegative myasthenia.
Well, that's one situation where the clustered cell-based assay for myasthenia can be really helpful, actually. And I don't know whether that's available in the clinics in your countries. But I mean, I'm saying that because I don't know exactly how else one would distinguish them, except that, of course, the thing about myasthenia is it responds to immunotherapies, and even perhaps a very short course of something like steroids or plasma exchange might be justified if you have a child with severe disease. Obviously, you would need to look at the thymus, because the thymus can be enlarged. And in fact, I remember a patient of John's who had thymoma at the age of 7 or 8. So it's not impossible that the thymus is going to help you make the diagnosis of myasthenia gravis. From that, I would go to the reviews of the genetic forms, because many of them have some distinguishing feature in terms of clinical symptomatology or weakness. And of course, quite a lot of patients now are given salbutamol, both for the congenital, but actually increasingly for the autoimmune forms. So that doesn't help you distinguish them. Both forms can respond to salbutamol. Again, something we don't really understand, but which empirically seems to be helpful. And I'm not an expert any longer on the congenital patients. There are so many different mutations now that I can't really say more than that.
Thank you. There's another question which talks about measuring complement levels during treatments like eculizumab. So are they really worth it? Monitoring if their complement levels change during the course of treatment?
I wouldn't have thought during the course. I would have thought that what's going to happen is that you would test the patient before you start the complement therapy, anti-complement therapy, to make sure that actually they've got complement activation is likely to be an important mechanism. Otherwise, you're wasting money. And you know, the companies don't like that much either because it doesn't do their statistics much good. So I think that measuring those the complement activation, which is something Kevin O'Connor's already doing, we've already set up a simple version to try and start measuring that more accurately, will be important to avoid treating patients who are less likely to respond. But not, I wouldn't have thought during the treatment. And in fact, the treatment seems to be so impressive that I can't really see the justification. The question is, when you stop the treatment, if you stop the treatment, how quickly does the complement come back? That might be something worth exploring.
The other question is about, and you, I think, mentioned that during your talk as well, the quality and sophistication of measuring the AChR antibody levels, which can be very, very heterogeneous. So the question asked is about a true cutoff level of antibody, since many labs tend to give their vague ranges, sometimes differential ranges. So, I mean, is this a...
Yeah, we used to have an equivocal range, I must say. And then the labs in England anyway, didn't like that. They said it's got to be either positive or negative. But that's, you know, there are always going to be some that are a little bit in a grey area, but it's a pretty small proportion of the total. The only thing you do have to be quite careful of, and perhaps this applies also to the genetic autoimmune distinction during childhood, is that some patients, you can't actually detect their antibodies initially. But if you come back again, as the disease progresses, you can find them. And I think that's because of, you know, presumably because of sensitivities of the assays. That's quite important. So I would always test again, perhaps in 2 or 3 months' time, a patient who you feel has got myasthenia gravis, but is actually seronegative for the available tests. So I think that's important.
So one last question before we move on to the next talk is about the clinical behavior of LRP4 agrin antibody positive myasthenia, based on your group's experience about their differential response compared to seropositive myasthenia.
I'm sorry, but we do not use LRP4. We have had, the assays that we've tried to develop, and I'm not sure what else is available actually, although I think the company may have one now, but we just don't think that the assays that one measures to LRP4 or agrin are specific. I mean, they're really non-specific, not just like Anastasia was mentioning that the specificity of some assays for serum are poor, but I mean, this is, you know, you really could, the studies that have been done tend not to have used good, randomized, blinded controls, put it that way. And I think they're sending a lot of patients who they think have got myasthenia gravis anyway. And so they jump at any kind of positivity, even if it's really quite minimal. So we don't use it, either of them. And we did look at both of them earlier than most people. We don't believe in them.
So thank you, Dr. Angela, for this excellent talk and discussion. For the want of time, we would have many questions, I know, in this subject, but I'll be moving to the next talk now. And so it's my pleasure to introduce Dr. Jonathan Cleaver, who's currently a clinical research fellow and honorary neurology registrar from the University of Oxford. He's had many awards to his credit and many publications in the field of neuroimmunology, and especially talking about encephalitis, and he's more than his academic field, he's also a black belt in both kickboxing and karate. Jonathan, I saw that in your CV, so I thought it's good to mention the extracurricular activities that you do. So I think he's going to talk about a wide dimension of a subject that has, I think, maximally evolved in the last 4 or 5 years, ever since we started to understand autoimmune encephalitis. And it's become so vast that, and in more and more training and teaching, I think we're becoming more and more sensitive in possibly considering AIE as a differential in people presenting with various immunological disorders. So Dr. Jonathan is going to speak on the immunology of AIE and give us take us through the journey of understanding how autoimmune encephalitis has evolved and how we understand it in the current era. So over to you, Jonathan, for this.
Thanks very much for the kind introduction. Can you hear me okay?
Yes.
Brilliant. It's a real privilege to be able to present alongside some of the leaders in the field. I'm going to talk to you today about the immunology of autoimmune encephalitis. I'm going to start with an overview broadly of autoimmune encephalitis, which we have discussed previously before. A basic introduction to the B-cell immunobiology, followed by concepts of immune tolerance and germinal centers, subsequently autoantibody production origins, triggers of tolerance failure, T cells in these conditions, immune trafficking, and following that, treatment. Since the discovery of HU and GAD65 antibodies in the 80s, the field has rapidly expanded with the discovery of myriad antibodies against both extracellular and intracellular neuronal and glial targets. Many of these antibodies being identified are against intracellular targets, and therefore, while a useful biomarker of both immune system activation and dysregulation, the majority of these intracellular antibodies are not proven to be pathogenic in the disease. Fortunately, a large proportion of the more frequently encountered antibodies are associated with more distinctive clinical and paraclinical features, which can help the clinician in deciding which test to order based upon the clinical phenotype. The epidemiology has also changed over time. You can see here by Dubey in 2018, between 2 decades, the incidence of autoimmune encephalitis has tripled from 0.4 to 1.2. This is contrasted with the infectious encephalitis, which has remained the same during these 2 time periods. This is probably as a result of increased awareness, increased sensitivity of the assays, and also discovery of new antigenic targets. At the time, looking at this older cohort, you saw different antigenic targets than we're used to in terms of their prevalence. And this French paper here on the right-hand side shows that the NMDA receptor, LGI1, and Caspar2 antigenic targets are the most frequently encountered antibodies that are targeting these particular antigens. The phenotypic spectrum has been quite well demarcated with the most common sets of antigenic targets. For instance, an NMDA receptor antibody encephalitis typically affects younger females, and this occurs with a multi-domain psychiatric presentation, multimorphic movement disorders, seizures, and so on. This is typically associated with antibodies of the IgG1 subclass with a putative mechanism of internalization via antigen cross-linking. This is contrasted to Caspar2 antibody diseases, which are typically affecting older males, and phenotypes can include isolated limbic encephalitis, neuromyotonia, Morvan syndrome, cerebellar syndromes, and pain syndromes, for example. The main IgG subclasses here are IgG4, and the putative mechanisms of pathogenesis here of the antibodies are functional modulation of the antigen or neighboring proteins. On the right-hand side, you can see that we've created a complex heat map of the different surface and intracellular antigenic targets, which are clustered based upon their similarities in terms of their phenotype, in terms of their neuroanatomic localization, where they affect in the neuroaxis, and also in terms of their aberrance of the investigations and treatment responses. Before we go into the granular detail of the immunobiology behind autoimmune encephalitis, I think it's important just to refresh our memories of the B-cell receptor and subsequent antibodies. The antibody is comprised of 2 heavy and 2 light chains, variable regions, the region that binds the subsequent cognate antigen. And essentially, an antibody is a secreted form of the B-cell receptor, the B-cell receptor being tethered to the membrane through heterodimers, Ig alpha and Ig beta, which allows for intracellular signaling when the cognate antigen binds the B-cell receptor. The concept of immune tolerance has been well established over time, and essentially what this does is put brakes on the immune system to prevent autoreactive B cells from progressing and maturing through the B-cell ontogeny. These can occur in different sites, such as in the bone marrow, in the periphery, later in the lymph nodes, and autoreactivity subsequently diminishes as you pass through each checkpoint, as expected. In terms of the different antibodies that are associated with different breaks in tolerance, I'm going to discuss about that later. But essentially, the body wants to maintain great antigenic diversity in order to fend off against foreign pathogens and also to survey against host cancer cells. So it has to strike a balance between deleting autoreactive B cells through mechanisms such as apoptosis, through receptor editing, which is mutations of the receptor in order to prevent it from binding that previous autoantigen, or through anergy, which is functional inactivation of the B cell receptor. Broadly speaking, there are a dichotomous view of how autoantibodies are produced, and this is a simplified schematic. These can be either within the lymph nodes or within the bone marrow. And as antigens are binding mature naive B cells, they can enter the lymph node and participate in either follicular within germinal center reactions, which I'll talk a little bit about later, and outside extrafollicular reactions. The extrafollicular reactions can generate, broadly speaking, predominantly IgM, which is an ephemeral antibody response lasting a T-half of 5 days. And within the germinal centers themselves, they can create class-switched antibodies, IgG, A, and E. Within the bone marrow, plasma cells can take residence, and they can increase their duration, their lifespan, from a few days to up to a decade. And as a result, long-lived plasma cells can contribute to up to 90% of the peripheral reservoir of IgG. More specifically, germinal centers are immunological basins within lymph nodes that allow for increased binding affinity and specificity of the B-cell receptor for the cognate antigen. And they do so through CD4 follicular T cell help and through professional antigen presentation via follicular dendritic cells. Processes such as somatic hypermutation, whereby variable region is mutated in order to increase the binding affinity and specificity for that receptor to that particular antigen, occurs. Furthermore, class switching, whereby the B cell receptor's immunoglobulin is switched from an IgM or IgG to IgG, A, or E's, can occur. As said previously, IgG can last for a lot longer, with a half-life of around 3 weeks, depending on the subclass, and IgM can last, has a half-life of 5 days, notwithstanding in conditions like NMDA receptor antibody encephalitis and aquaporin 4 neuromyelitis optica spectrum disorder. There have been reports of IgM-specific antibodies lasting for a lot longer than their expected half-life suggests. And this can occur at the peak of disease during relapses or during the onset of disease, suggesting that there is ongoing germinal center reactions at the core of the immunopathogenesis behind these disorders. Further evidence for germinal center activity are substantiated with these reports, such as the reports by a colleague, Dr. Adam Al-Dawani in Brain, published in 2022, who used aspirates of deep cervical lymph nodes from patients with an NMDA receptor antibody encephalitis. And essentially what he found was the cells cultured from these lymph node aspirates were able to produce NR1 antibodies, which is the immunodominant subunit of the NMDA receptor, ex vivo. Furthermore, and I'll talk a little bit more about this later, the ovarian teratomas isolated from the paraneoplastic NMDA receptor antibody encephalitis patients had features reminiscent of germinal centers on immunohistopathology, similar to what Professor Vincent was suggesting with thymoma previously. In the bottom left, you can see that distinct HLA associations have been discovered with LGR1 and Caspar2 antibody diseases, suggesting T cell help within the lymph nodes are important, antigen-specific T cell help, that is, and I'll talk about that more in the T cell section. And in the top right, you can see in this Nature Review paper by Bo Sun that the LGI1 specific B cells in the box and whisker plots here shows that there are more heavy chain variable mutations in LGI1 specific B cells than non-LGI1 specific B cells, suggesting somatic hypermutation, i.e. germinal center reactions, are important parts of this pathogenesis. Substantiating this further, Jakob Thierl had published a paper in PNAS recently this year, and he looks at the antibody secreting cells and B cells from the CSF of patients with LGI1 antibody and Caspr2 antibody and encephalitis. He looked at the transcriptomic data of these antigen-specific cells, and what he found is if you revert those cells back to their germline, these are also called unmutated common ancestors, or UCAs for short, they either abrogate or significantly reduce their binding on antibody binding assays. At the same time, the phylogenetic distance is greater between that founder clone and the UCA than the intraclonal distance you'll see within other CSF clonally related cells. This shows two things. One, again, that germinal centers are responsible for producing these antigen-specific B cells and antibody-secreting cells within the central nervous system compartment. And also, this process is occurring in the periphery, not in the central nervous system, a paradigm that exists in multiple sclerosis. And in the bottom right, rituximab, which does target those B cells which enter and are released from germinal centers, strongly abrogates ACPOR4 specific germinal center activity in patients with ACPOR4 NMO spectrum disorder, as highlighted in this paper by Valentina D'Amato in PNAS. Next, triggers for tolerance failure are myriads and include tumors, infections, and various medications. Now, it has long been known that tumors are associated with paraneoplastic antibody, CNS antibody disease, and they were thought originally to be more associated with intracellular targets such as HU, MAR, YO, amplifizin, etc. And they still are, and to a high frequency. However, it has emerged over a decade or so, these are also associated with various surface antigenic targets, including to a variable degree dependent on the demographic, NMDA receptor antibody encephalitis, and so on, as this table suggests. On the right is a nice schematic with a traffic light system which shows the different antigenic targets that are associated with different risks of cancer. Next, the tumor biology is important to understand. Now, if you have an antibody and a tumor, in order to directly link those two, it's axiomatic that the tumor should be producing the antigen, the target antigen of interest. And indeed, on the left, you can see this histopathological slice, which shows in the patient small cell lung cancer and neuronal antibodies that the neuronal antigen is expressed alongside different neuroendocrine cells. In the middle, this is the teratoma slice from Adam Malzwani's paper in Brain, and you can see that the B cells and T cells are neatly apposed alongside mature dendritic cells, and there is the immunodominant NR1 antigen within these ovarian teratomas, suggesting these have all the infrastructure of a germinal center. And on the right is a schematic from Dr. Handel's review in Nature Review Neurologies that essentially highlights the important positive and negative selection of T cells within the thymus that is regulated by thymic epithelial cells in order to prevent autoreactive T cells from aggressing into the bloodstream. As Professor Vincent mentioned in her talk, with thymomas, this can cause dysregulation of this process and can be associated with germinal center-like activity as well. Other triggers for tolerance failure include infection, and the most commonly associated infection with later autoimmune encephalitis is that of herpes simplex virus encephalitis. Later autoimmunity following the index HSVE typically occurs around 30 days after the index illness, and the emergence of NMDA receptor antibodies are most commonly associated. But in older adults, about a third of patients harbor yet unknown antigenic targets. The mechanism behind this is currently unclear, but it's thought that immunoprivileged antigens could be released. It's plausible that these could be released from the massive brain damage that ensues as a result of HSVE, draining through into the meningeal lymphatics, into the deep cervical lymph nodes, for an autoimmunization process to occur. This requires further research. Immune checkpoint inhibitors have revolutionized the treatment of various different cancers, including melanoma, non-small cell lung cancer, etc. However, they do come with a degree of neurological immune-related adverse events in 1 to 5% of patients. These can be either peripheral nervous system autoimmune events or central autoimmune events. The latter typically occurs, interestingly, with immune checkpoint inhibitors against non-small cell lung cancer. And there can be various different antigenic targets associated with ICIs, which are typically quite steroid responsive. including intracellular targets, synaptic targets, and yet unknown antigenic targets, as highlighted by this paper in JAMA in the bottom right. You can see there's a facial sensory syndrome that was published here by our colleagues, and that there was some nice binding, antibody binding, you can see here in green, alongside the MAP2 staining of the rat hippocampal neurons, suggesting that there is strong synaptic binding here. T cells in CNS autoantibody disease is an underexplored area, and this paper that Professor Vincent was a part of in 2012 in Brain highlights that the different intracellular antigenic targets, antibodies, do have CD8 T cells in close localization proximity to neurons, and also their effector enzyme, granzyme B, are polarized towards those neurons, suggesting that they are not only in the right topographical area, but their effector enzyme is also pointing towards the right effector cell. And on the right is a schematic of how antigen presentation to CD4 T cells allows for their subsequent activation and polarization, and therefore leads me on to talk about HLA associations, which are the human variants of the MHC, and essentially important in activating T cells, which are peptide specific. And Dr. Binks in Brain associated or found a strong association between DRB1701 and LGR1 antibody disease in 90% of patients compared to 25% in healthy controls. In CASPR2, there was an association with DRB1101 in 50% of patients compared to 20% of healthy controls. And later studies have shown that in CASPR2 isolated limbic encephalitis patients, this risk allele association increases to 95%. There are also strong associations more recently with IGLON5, with DRB1101 and DQB1501 as well. There are looser associations with the other antigenic targets that need further worldwide population evidence. Next, I want to talk about immune cell trafficking into the central nervous system, which again is a rather underexplored area. Most of the work stems from multiple sclerosis and T cell trafficking. We know that natalizumab, which blocks the VLA4, essentially is very highly effective in multiple sclerosis. And essentially what happens in order to traffic T cells across into the brain requires an initial inflammatory insult to upregulate adhesion molecules and therefore decelerate subsets of T cells so that they can become activated, adhere to the endothelium of the blood-brain barrier, crawl and diapedese through, marshaled by a cytokine and chemokine gradient to their effector tissue and subsequently to their effector antigen. The mechanisms behind B cell trafficking into the brain are much less well understood. More recently, there's been a paper in Science suggesting and implicating ALCAM, an adhesion molecule that may be more specific to B cells rather than T cells, but requires further work. Humoral or antibody mechanisms of trafficking across into the brain are much less well understood, and evidence is garnered from human commensurate disease in animal models, which suggests that it's not necessarily sufficient for peripheral pathogenic antibodies to simply cross over into the brain without any additional help or an additional inflammatory milieu to break up the blood-brain barrier and facilitate this process for CNS autoantibody disease, similar to the human counterparts. Subsequently, often antibodies are directly injected into the central nervous system in order to circumnavigate this. Finally, I want to talk a little bit about treatments and the B-cell lineage. It's important to treating clinicians to know where the treatment is acting along the B-cell lineage in order to see potentially where there may be pitfalls along the way in the treatment. And I'm going to focus on rituximab initially, the CD20 monoclonal antibody. As you can see, it relatively spares antibody secreting cells, and as Anastasia mentioned, that has a relatively limited effects on reducing the antibody titers, especially in aquaporin 4 neuromyelitis optica spectrum disorder, that curiously has a very effective clinical effect. This suggests that it's not simply the pathogenic antibodies that are required to be abrogated in order to mitigate disease and potentially implicating germinal centers in the pathogenesis again by virtue of the treatment effects. It is conceivable, however, that inebilizumab, CD19 monoclonal antibody, which essentially inhibits more broadly the B-cell ontogeny, could be more effective. However, if the protagonist in the immunopathogenesis of these CNS autoantibody conditions is predominantly focused around germinal centers and certain antibody-mediated conditions, then both rituximab and inebilizumab may be equally effective. There are also other experimental treatments that are emerging in the CNS autoantibody sphere. We did mention a little bit about FcRn inhibitors. There's currently a Legion trial on LGI1 antibody encephalitis currently underway, which essentially inhibits the recycling of IgG and then targets the IgG to the endosome for subsequent degradation. Daratumumab is a medication that has stemmed from the hemo-oncology sphere, which targets predominantly antibody secreting cells, but also early progenitor cells within the bone marrow. This has been used in a few clinical cases recently published in the European Journal of Neurology. However, these were a heterogeneous cohort that was severely disabled, so true randomized clinical trials are required in order to see whether this should be implemented or not in clinical practice. CAR T-cell therapy is another emerging precision therapy for CNS antibody-mediated diseases. And this chimeric autoantigen receptor T-cell therapy has been born out of the chimeric antigen receptor T-cell therapy in the hematology sphere. And essentially what they're trying to do with CAR T-cell therapy, the autoantigen receptor T-cell therapy, is pull out the B cells that are antigen specific for that target antigen. And indeed, Harold Pruss's group in Germany have employed this in NMDA receptor antibody encephalitis in preclinical studies, in vitro studies, and also in animal models. And this is shown to be very effective in abrogating certain monoclonal antibodies from binding. It's also been very effective in animal models of the disease. However, it is important to note that in clinical practice, if we're basing this upon chimeric antigen receptor T-cell therapy, the ex vivo production and nurturing of these T-cells takes many weeks. And at the same time, this patient might be deteriorating whilst you're waiting for these therapies to actually come to fruition. At the same time, about 30% of patients get a cytokine release syndrome, and these can have quite detrimental effects and side effects on the patients. So their role within CNS autoantibody-mediated diseases are currently unclear and require further research. So that brings my presentation to a close. I want to thank you for providing me the opportunity to speak amongst some of the very prestigious leaders in the field. I welcome any questions. I'm sure some of my co-presenters will be better placed to answer them, but I'll try my best to answer them as best I can. Thanks very much. I want to acknowledge all the Oxford Autoimmune Neurology Group, the Mayo Group, and in particular, Professor Suresh Irani, who has asked me to do this talk on behalf of himself today, and also the Indian Academy of Neurology for hosting today. Thanks very much.
Thank you, Dr. Jonathan. I think that was a very detailed and a lucid coverage of autoimmune disorders, especially with reference to CNS autoimmunity and autoimmune encephalitis. I think one of the questions I would just like to ask you, because I'm waiting for questions to be posted, is that most of these disorders tend to have a predilection to one part of the CNS. So would you like to, just give your observations on how, why these specific regions of the brain get predilected with a specific antibody? Are the targets more specific, or they're still heterogeneous, but they tend to afflict those areas more specifically?
I think that's a really good question, and it's certainly an area of future research that we aren't sure about. And if I take some of the obvious tolerance breakdown triggers, such as infection, we know that the NMDA receptor antibodies typically emerge after herpes simplex virus encephalitis. Now, this may be by virtue of the fact that the temporal lobe structures are enriched with NMDA receptors. They're also enriched with the other antigens. I think it's going to be a combination of host factors, the HLA predisposition, and also whether there are certain breaches in the immune tolerance early on in those patients, and essentially they are predisposed towards later autoimmunity. We know that other autoimmune diseases are associated with some of these CNS autoantibody diseases as well. In terms of tumors, we know that they host the antigen, and therefore that's quite an easy source of that particular antigenic target. But in terms of knowing the precise mechanism why other antigens are being targeted is still unknown. We do know there's some evidence that's starting to emerge that innervation within the thymus can actually tolerize the patient against that particular antigen. So for instance, in LGI1 or Caspr2, there's been some early work that's been unpublished. I believe that if you have the LGI1 or Caspr2 innervated neurons within the thymus, then that can tolerize the patients against that. So maybe the absence of that could allow for central tolerance breaches in those cases.
So another question is about any, although I didn't really understand the question, but was talking about Iglon-5 antibody encephalitis cutoff point to prevent neurodegeneration. I don't know whether it is meant about, is there any cutoff point in the Iglon-5's clinical severity, or it is about its titers, but how does it affect on the long term about the, the potential long-term effects on neurodegeneration? And what he has added now, the attendee, is about treatment starting for Iglon-5. I think that's what it was meant.
So there was a recent paper in Brain, I believe, a couple of years ago that looked at Iglon-5. I don't know the first author by hand. I'm sure some of my colleagues will know this. But essentially, early treatment seems to be beneficial in these patients. So there's almost a dichotomous process by which you get a surge in autoimmunity at the very beginning of the disease, and then neurodegeneration may ensue later on. So it may be an inflammatory stimulus at the very beginning, but later causes tau-related neurodegeneration. So starting treatment early on is important in influencing outcome in these patients, according to that paper in Brain. Starting treatment with steroids, for example, obviously depending on the patient, depending on the risk factors of that patient, etc. And then other treatments that can be beneficial are rescue therapies like plasma exchange or IVIG. And rituximab as well has been shown to be beneficial potentially in the early stages of the disease. But if this is caught late, then neurodegeneration will likely take over as far as we know and the evidence, and actually you get diminishing asymptotic returns from immunotherapy at that stage.
One last question is about the future or the present of CAR T cell therapy. One of the attendees has asked about, would it be a complete cure and how it is likely to be used upfront in the near future?
I think that's a great question. I think that I highlighted some of the pitfalls that we have currently. I think potentially those that are more severe, it may have a role. Potentially those that have a longer immune responsive illness. So for example, in NMDA receptor antibody encephalitis, the CAR T cell therapy have been used preclinically. They haven't, to my knowledge, elsewhere in other antigenic targets, but in NMDA receptor antibody encephalitis, quite short-lived monophasic in general condition. And therefore, growing these CAR T cells ex vivo and then treating the patient with them, which also has a significant side effect profile as well, which can be life-threatening in itself, I think may not have as beneficial a role in those that are longer-standing CNS autoimmune diseases, which are still immune responsive and have an antigenic target. I think there could be a role there, but obviously further work is required in order to substantiate that.
So thank you very much, Dr. Jonathan, for this wonderful talk and discussion. I now move on to the next talk. For the next talk, it's a pleasure for me to introduce Professor Dr. Khadilkar, who we have known as a very senior colleague and a mentor for many, many years. Professor Khadilkar is the Dean Medical Faculty of Department of Neurology at Bombay Hospital Institute of Medical Sciences and currently the Professor and Head of Department of Neurology as well. He was the ex-professor and head Department of Neurology at Grants Medical College and has been the editor-in-chief of the prestigious Annals of Indian Academy of Neurology Journal, which is the official journal of the Indian Academy of Neurology, and has been previously closely associated as the president of Indian Academy of Neurology and the Nerve Muscle Society of India. His area of expertise is his interest in neuromuscular disorders. And without losing much time, I would now request sir to talk about the immunology of the peripheral nervous system, from neuromuscular junction to central nervous system. Now we go to the important part of the peripheral nervous systems. Over to you, sir, for this.
Thank you. Thank you very much, Rohit. And it's a fantastic program that you got together. I enjoyed all the lectures. They were fantastic. And I also noticed that I am the only clinician in the group. So I think the talk will be partly clinical and partly in the lab. So the topic that you've given to me is inflammatory neuropathies. So let's introduce the topic. When we look at inflammatory neuropathies, there are basically three common processes pathogenetically that go on. One is axonal dysfunction, second is demyelination, and the third is axonal structural damage. I think I have deliberately separated axonal dysfunction from axonal structural damage, because that's where the changes are happening and that's where the new things are coming up. Conventionally, as we look at the immune-mediated neuropathies, we basically have the acute and chronic settings. And in acute setting, you have the AIDP or the classic GBS. You have the MAN and AMSAN. You have the Miller-Fisher syndrome. And on the chronic side, you have CIDP, multifocal motor neuropathy, CANOMAD, anti-MAG neuropathy. And on both sides, there are more, but these are the principal conditions. If we look at how this field has developed, I think first there were the clinicians who basically divided peripheral neuropathies into length-dependent and non-length-dependent, which we now know is demyelinating and axonal. After the clinical differentiation of peripheral neuropathies into length-dependent, non-length-dependent, sensory, motor, autonomic, proximal, distal, and what have you, the electrophysiologists came in. Once the electrophysiologists came in, the slowing of the conduction, the latencies, and all the different parameters that they saw, they were able to tell us demyelinating and axonal as the primary process is going on. And I think that made us quite a bit rigid about these two classes of neuropathies, demyelination at one end and axonal at the other end. Then the other techniques, the pathologists showed us that there are inflammatory cells in the nerve biopsies. And therefore, you knew that on both sides, there were inflammatory conditions. And then is the era now of antibodies. And really now what is happening is that the distinction between primary demyelinating process and primary axonal process is getting a little blurred. And the pathophysiologies are emerging. So that's going to be the focus of the discussion in the next few minutes. So what I'm going to do is first I'll go through some of the conventional work and then I'll come to nodopathies. So basically, as we clinicians know, GBS or AIDP is acute to subacute, largely motor, areflexic paralysis with variable autonomic changes, and a lot of clinical variants we know. The important part for today's talk is the association of GBS with the antimicrobial prodromes or the antimicrobial situations coming before the GBS develops. And we know that there's Clostridium jejuni, the pneumonia, Haemophilus pneumoniae, CMV, and the concept of molecular mimicry. So I think from the antibody point of view, GBS, the clinical observation that there is a prodrome which links to infectious illnesses, which leads to molecular mimicry, is probably the first evidence in the evolution about the antibody-mediated inflammations. So what's known in what we call AIDP or classic demyelinating GBS? We know that pathologically there is segmental demyelination. There's infiltration with T lymphocytes and macrophages. And the macrophage associated cytokines increase like the TNF alpha and the interferon gamma, and they correlate, their levels correlate with the severity of the disease. There's not only a T cell response, there's also a B cell response to various myelin antigens, which as yet we don't know what they are in cases of classic GBS. Then there is a contribution from matrix metalloproteins, inflammatory cytokines. So we know that there is demyelination. We know that there is a T cell factor. We know that there's a B cell factor. But we don't know which antigens this immune response is targeted against in most cases of classic GBS. Then you have the AMAN and the AMSAN. AMAN, as you know, was described by Chinese and American groups together on a summer epidemic in children in China, where clinically there is involvement of the motor axons in the absence of demyelination and in the absence of sensory involvement, which we now know is an antibody-mediated process against the axolemma. So this was the second one, where second of the acute conditions, where instead of demyelination, you had an axonal pathology. And AMSAN is the third one, which is supposed to be more common in Asia and South America, where the sensory disturbances are there in addition to the motor disturbance. And these two may actually be the same disease with different severities. So what's known about AMSAN and AMAN and AMSAN? This is where I think first time the gangliosides as antibodies came into picture. And what are gangliosides? They're major constituents of the nerve cells, which help growth, development, and repair of the nerve cells. And they also help in neural and glial interactions. And like in the classic GBS, we did not know which are the myelin antigens. Here we know that there are certain specific gangliosides which result in these entities: the GM1, the GM2, the GDA, GDB, and GQ1B. Now, the first three are known to be associated with Campylobacter. So we have further proof that this molecular mimicry, which particular gangliosides take part in the pathophysiology. Now, this is a cartoon to show. There is node of Ranvier in this cartoon, but I'll come back to the node of Ranvier. So here you can see how the AIDP and AMAN, where the targets are. In AMAN, the target is in the axon, and on the AIDP, the target primarily is the myelin. And then we'll touch upon Miller-Fisher syndrome, which we know is a combination of ataxia, areflexia, and ophthalmoplegia with very little motor and sensory deficits. And most clinicians will also, they appreciate that the ataxia of Miller-Fisher syndrome is a little different from the classic cerebellar ataxia that you get. Now here again, the molecular mimicry is documented with Clostridium jejuni, but the antibody is different, which is GQ1B. And in Miller-Fisher syndrome, there was some documentation of reversible conduction failure, which again, I'll come back to. So at the present point in time, we know that a lot of antibodies are the reason why the pathophysiology of inflammation and the pathophysiology of acute and chronic demyelinating and axonal neuropathies occur. And this chart shows you how many are known in the GB syndrome, how many are known in AMAN, AMSAN, Miller-Fisher syndrome. And similarly, in the CIDP spectrum, the MADSAM spectrum, the multifocal motor neuropathy, and so on. So the list is quite big now to which antibodies are known. So how do gangliosides participate in this process? The two gangliosides or more than two gangliosides form complexes. And the epitopes that are expressed by complexes of gangliosides are much different than gangliosides themselves, each one of them. And they activate the complement pathways. And you know that certain antibodies will be associated with severe disease. So it also has an implication not only in pathophysiology, but on the general outlook of what sort of conditions are you going to see, and what therapy should you use, and perhaps what the prognosis will be there. So these are the ganglioside antibodies in different diseases that we know up till now, in MMN, MAN, AIDP, and various other conditions. You now know the associations with gangliosides. And this cartoon shows you how the T helper cell and B cell and the plasma cell and the gangliosides and how they sit on the motor neuron. The second part is the complement system, which is an innate immune system consisting of approximately 30 proteins. And in 3 different pathways, the classic, the alternate, and the lectin pathway, they activate sequentially. First the 3, then the C5, and then the others. And there's a complement, the MAC, membrane attack complexes, which get deposited. And that's known in GBS as well as Miller-Fisher syndrome. And we go back to the same cartoon. On the left side, you will see the complement activation, how it takes place, and multiple steps that occur. And then the membrane attack complex gets deposited. Similar to the AIDPs, in CIDP patient also, you know that there is a pro-inflammatory and regulatory cytokines are elevated in the CSF. Tumor necrosis factor levels are raised. There are activated T cells, which are mainly CD4, and the further steps that these cells do. Now, in the CIDP area, a very interesting thing is happening, that just like GBS, where you don't know the antibodies, the classic GBS, but then there are varieties where you know which gangliosides are affected and which cytokines are affected, which you're separating out. Like MAN has gone separate, MSAN has gone separate. So wherever we are detecting clean associations between the antigen, antibody, and the inflammatory process, that's coming out of the basic umbrella of the acute inflammatory neuropathy or the GBS umbrella. Similarly, in CIDP umbrella, wherever you have the antibodies detected, those conditions are coming out. So possibly as we detect more and more antigens and antibodies as time goes by, the primary umbrellas will shrink and the small entities will become larger. Right. With this, let's go to the Neuropathies, which is one of the important topics at this point in time. So like I introduced the topic, from demyelinating and axonal, we all know as clinicians that some of our GBS, some of our CIDPs do not respond too well to conventional treatments, and some unexpectedly improve very well. So the concept of paranodopathy was initially defined in some axonal variants of GBS like MAN and MSAN with anti-ganglioside antibodies. And then groups started working on the nodes of RANVA, and they showed that node of RANVA was the seat where the pathophysiology occurred. Now, the important part of this concept is that a pathophysiological continuum is projected from a reversible conduction failure to axonal degeneration. That's why in the first introductory slide, I kept axonal dysfunction separate from axonal structural change. Some patients will go on to recover, their conduction failures will recover, and in some others, the axonal structural damage will occur, in whom the disease will be very severe. Now, the node of RANVA has been dissected to the nodal, paranodal, juxtaparanodal, and the internodal areas. And in this cartoon, you will see how the myelin anchors on the axon, which is again in this concept an important point of pathophysiology. Now, the antigens in these nodes have been analyzed in good depth, and there are IgG4 class antibodies there. So there are neurofacins, Neurofacin 186, 155, and 140. Then there's Casper2, there's Contactin, Gliomedine, and there are more as well. So different regions within this the node, the paranode and juxtaparanode have these various antigens and antibodies. And the information that we know up till now is tabulated here. That node had certain gangliosides and gliomedine. Paranode has the neurofacin antibodies, the gangliosides, the contactin, the Casper1, and the juxtaparanode also has other ones. Now, there's this beautiful article by Ansini, who in fact has written 2 articles 11 years apart as to how this concept of nodoparanodopathies changed over time. And I think these 2 are very nice articles to read. Now, in this cartoon, on the left, you see the normal node, the normal myelin, the normal axon, and how they're anchored. And you see on the right side that the myelin has got de-anchored from the axon. So this is not a myelinopathy in that sense. It's de-anchoring of the myelin from the axon, leading to dysfunction of the myelin. So this is where a kind of unifying concept comes, that axon and the anchoring of the myelin is the area where the difficulty is. And this cartoon lines out which antibodies are involved. Right. So this we saw when we started, but I'm bringing it back again for reversible conduction failure. Reversible conduction failure mimics demyelination, but is an axonal problem. And if you do serial electrophysiological studies, you will see improvement. Like this is one of our patients. Day 1, you can see the motor NCS on the left side. And on the right side, you see day 7, how beautifully the conduction failure has recovered. Now, that can't happen in what we conventionally think is a major problem, which demyelination leading to conduction block. This is the reversible failure, or put by some authors as axonal conduction block. Just to say that some of these also have central demyelination and some associations with the MOG antibody and others. Right. So, as a clinician, when does one suspect a nodo or paranodopathy? Acute or subacute onset with predominantly severe motor neuropathy, and I think 2 caveats could be added. Rapid progression, going on ventilator within a day or 2, and probably the conduction becoming absent. Disability at the nadir being severe in acute and chronic patients, and presence of sensory ataxia, sensory tremor. Severe neuropathic pain, and cranial neuropathy. So, in the acute, subacute, and chronic, all settings, a severe neuropathy, rapid nadir, sensory ataxia, tremor, neuropathic pain, and cranial neuropathy seem to be more common in patients who will have nodo or paranodopathy antibodies compared to those who won't. So that's the setting where one would suspect it. Now, it's rather important in a situation like ours where you can't send antibodies for everyone who comes with an acute, subacute, or chronic neuropathy to you. So this may help selection, but from the net, you will probably lose some. Then associated disorders like a nephrotic syndrome or a lymphoproliferative disorder. Membranoproliferative nephropathy with a neuropathy almost strongly talks of an IgG4 mediated disease. Electrophysiologically, the reversible conduction failure that I mentioned. Then other non-specific ones are reduced motor neuron conduction velocity, marked prolongation of distal motor latencies, and marked prolongation of the F wave. Early axonal loss. Radiology can be quite helpful, and you can actually see nerve root and plexus enlargement, certainly in chronic cases, but sometimes even the early patients, you can see the enhancement and the thickening coming up in a week or two. Serial electrophysiological studies are most important to look at reversible conduction failure. And if you see it, then you really lean towards a nodoparanodopathy. MRI neurography I mentioned. I don't think we have done nerve biopsy to pick this diagnosis up. And of course, antibody testing in the venous blood. Right. Now, with this background of the immunopathogenesis and some of the newer aspects related to the nodes of RANVA, the two treatments that work, how do they work? So how does IVIG work? What's the mechanism of IVIG? It neutralizes pathogenic autoantibodies. It inhibits autoantibody-mediated complement activation, which is an important step in the pathogenesis. And it alters the FCR expression and redressing altered cytokine patterns. So it works on the immune response. And the result, as we see, is improvement of the axonal function, reduced nerve injury through decreased complement attack, and faster clinical improvement. How does plasma exchange work? It removes autoantibodies, it removes cytokines, it removes the complement that is activated and settling in, and it also probably removes unknown humoral factors that alter the lymphocyte function. And again, you see the same results: improved axonal function, reduced nerve injury, and clinical improvement. So I think we've gone through primarily the fact that we started off with clinical classification of neuropathies, then we had electrophysiological rigid divisions between demyelination and axonopathy. Then we had pathology to show that there was inflammation. Then we have the antibodies to show how the mechanism of nerve injury. And the ganglioside antibodies came first, and we saw what are gangliosides. We saw how they activate cytokine. Then we looked at the new concept of, relatively new concept of nodoparanodopathy, the structure of the node. We looked at which IgG4 class antibodies are concentrated there, like the neuropathic disease, the gliomedin, and so on and so forth. Then we looked at a little bit of how the complement and the IgG play a role in this pathophysiology. And since it's not a scope of this this talk, because we focused on the pathophysiology, but I think this is leading to more substantial immunotherapy for these patients. I think when we didn't know about a lot of these things, besides first IVIG, there was hardly anything. And I remember a patient whom I saw in, I think, late 1990s, where the patient did very badly, but after first IVIG, there was nothing more that could be suggested, and he just went on and on ventilator for a long time. But from that time, I think we've come quite far in understanding, and we now use more immunotherapy, in particular rituximab, but that's a separate topic. So I'll stop there and would like to thank the Indian Academy for asking me to be here. It's an absolute pleasure. And Rohit, nice to see you again. I think Netra has left, but I met her recently in a meeting. And all the lectures I heard were fantastic. Thank you very much, Rohit.
Thank you, sir, for this excellent presentation. I think it was extremely simplified, and journey to making it understand to the clinical from the bench to the bedside was extraordinary. I have one question for you, sir, based
Yes.
on this whole concept that we are getting closer to and also getting blurred about, is when do we say this is a usual form of bad GBS, or are we now trying to slowly classify them into more discrete things? Because I think what is happening in practice is that once patients are not improving or they're coming with a very severe disease, we tending to always think in the back of the mind that are they truly the ones we used to think as AIDP or AMAN variant, or our understanding has improved to call them nodopathies, because testing is not so freely available and it's not easy and it's not accessible So should we be moving on for immunotherapy, which is level 2 in every patient whom we feel is
Yeah.
not improving?
Right. A very good question. But I think here again, we are going to go similar to the autoimmune encephalitis, I would think. That there are patients in whom antibodies come positive, and then you have the conviction to go ahead and do. But there are other patients who are clinically look exactly the same. You don't get the antibodies, but you ultimately end up doing the same things. So I think here again, we're going to go, I think, the same way. We are going to look at a case-based review of how severe the situation is. What are the other factors how are the other systems affected? And we probably, in general, are going to be a little more proactive for immunotherapy, certainly in presence of antibodies, and sometimes even in the absence of antibodies.
What about your take on steroids, sir? I mean, that is kind of the chapter which is not yet fully closed, but closed based on the previous literature, and a lot of,
Yes.
I would say, contradictions to the whole concept of steroids and GBS still exists.
Yes.
So I don't know whether these are those patients where steroids should as well be used, because we still don't use them.
Yes. Again, a very good question. Most studies on neuropacine 155, neuropacine 186, and some of our local experience in Mumbai, steroids do help in acute as well as chronic presentations when these antibodies are positive. Now, when you get a GBS patient who is very severe, you don't have the antibody, or you send the antibody and it will come back in a week or 10 days. I think carefully one could look at it. There is, I think, a place with the knowledge of the antibody and the pathophysiology in acute settings as well. It doesn't seem that watertight now that corticosteroids just don't help acute severe neuropathies.
There's one question from the audience. I think 2 questions I've covered directly or indirectly, but the one question is about how long to give rituximab in neuropathies. Like, would it be just an induction, or would you want it to be continued?
I think it's case-based. Also, there is a lot of current work on low-dose rituximab, like in other places as well. So I think it's an open-ended question and a case-based decision.
Any comments from our other colleagues, Professor Vincent, Dr. Jonathan, or Dr. Anastasia about this concept? Any personal experience or any suggestions?
Well, I just it's not really quite what you were talking about, but I do think it's intriguing and probably quite important to worry about the ones we can't find antibodies in, because what generally happens, certainly in myasthenia, is that they don't get treated quickly. And of course, with some of these diseases, the longer you wait, the more problem there might well be, more damage, permanent damage. And I don't know how you feel about it. I don't know what Anastasia does, for instance, in the autoimmune encephalitis, but there really ought to be some other way of determining whether a patient has an immune-mediated disorder other than a specific antibody. So if there was some sort of biomarker that we could say, they've got this cytokine or they've got something, don't know what it might be, that just helped you decide it was going to be autoimmune, even if you couldn't find an antibody, and to start treating as soon as possible. So what does anybody think about that?
I think that, I don't see a lot of peripheral cases in my clinic, so I don't, maybe I've seen one neurofasting case, so I don't, like, our peripheral people see them, but I think that the cases that we think about those, we will look for the nephrotic syndrome to think about contactin 1. We will look for the other systemic things that might also help to say that this is something more autoimmune. For example, in my clinic, if we say for CNS people, we will look is there coexisting autoimmunity, family autoimmunity, like cancer that can do the paranodoplastic, but it's just not enough. So practically, you kind of get all this clinical and your exam, and then after a while you get a feeling for these patients, but still there are patients that you're not so certain. So in our clinic, we always kind of have a very definite way of doing this, saying that this is what my baseline outcome measure is, and I'm going to treat the patient, and they will compare, and if after 3 months of treatment they have 50% reduction of seizures or clear improvement, that tells me that it's probably autoimmune, even if I don't have the antibody, even if the picture fits. That said, the caveat with that is, like, I have patients that will need Cytoxan in order to have stabilization or improvement. So if I do a 3-month steroid trial, it might not be enough, but that's one way of going around it. We've started looking at the cytokines of like different cytokine signatures in all of the autoimmune encephalitis. We just had a paper out on sarcoid compared with others. They can help with diagnosis for sure, but my experience has been by looking now at different antibody positive cases as well. They can be very different depending on the pathophysiology. So that you would say, LGA1 and GABA B, they seem to be both antibody mediated. Why wouldn't they have the same signatures? And they don't necessarily. So it's very difficult to, I think, for me to find the one marker, but hopefully if you combine your cytokines, your antibodies, your clinical acumen, all the family history, you'll get closer. But I wish that we will find one. That would be great. Because the misdiagnosis is just getting both sides now. We underdiagnose and we overdiagnose, and like it's a very common theme now.
Jonathan, you have any comments on that?
Yes, I agree with what Anastasia says. I think it just comes down to the clinical observations to start with. And I've only seen 1 or 2 Paranodopathies, but looking at the tremor, for example, in neurofascian, or the nephrotic syndrome in contactin, and then reducing that down, I think having those observational cytokines is a good way of doing that. Obviously a part of the picture, but not fully telling us what's going on. And then I was wondering whether different isotypes of the antibodies have also been explored, like IgM or IgA of the antigen-specific antibodies. And I wonder whether those could be markers as well, that something is going on early on in the disease. Has that been something that's been explored? It's not something I've come across.
Well, people do look for IgM, of course, and your lab has done so quite a lot. We looked in Myasthenia. I don't think we've ever found an IgM to something which hasn't already got an IgG antibody. And I mean, I worry about this because we've still got, it's like however many, even if you do find more antigens in Myasthenia, there's always more and more seronegatives. It's actually because the clinical diagnosis is fairly specific. If you've got the symptoms and the fatigability and the EMG findings and jitter and response to cholinesterase, then, for instance, it's pretty easy to say this patient's sort of 90% likely to have myasthenia. And then you find that they've got no antibody. And we've been looking quite carefully for many years, and we haven't sorted out anything that's useful apart from MuSK and AChR. So I hope that you'll be more successful with your diseases.
Okay, so for the want of time, on behalf of the Indian Academy of Neurology and the Autoimmune Subsection, and on behalf of my co-chair, Dr. Netravati, who had to leave for some urgent meeting, I thank Professor Angela Vincent, Dr. Anastasia, Dr. Jonathan, and Professor Khadilkar for having taken out time and delivered such wonderful talks. I think this whole concept and the basis that we have covered today will help a lot of our colleagues as well as students and fellows and residents to understand the diseases better. I also thank the IN Digital team on the back end to have taken care of the AB and the discussions as well as the communication. So I thank you all once again, and please have a good day, and we hope to connect sometime in the future again on one of the webinars of the Indian Academy of Neurology, or hopefully see you in person in one of the Indian Academy of Neurology meetings. Thank you very much.
Thank you. Thank you, Rohit.
Very, very enjoyable. Thank you.
Thank you.